This is Robotic Inguinal Hernia's tips and tricks. This is a 44-year-old gentleman who presents with a right-sided inguinal hernia. Here you can see after our port placement, we begin our dissection, creating the peritoneal flap as lateral to our port as possible. We are working medially towards our medial umbilical ligament. Here we're using our fenestrated bipolar forceps as well as our monopolar scissors. We continue this back and forth motion laterally to medially to avoid working in a narrow space. We are also careful to control all hemostasis as we continue our dissection. As you can see, we use not only the tips of our instruments but the robotic arms as well to apply adequate traction to continue our work in an avascular plane. Although not required in this patient, sometimes if the peritoneal flap is too thin, we create a small transversalis sling to prevent any defects in the peritoneum. This would then be rectified further down in our dissection. As we continue this dissection, we work medially to identify the pubic tubercle, and once this is done, we continue our dissection of the hernia sac. Once we reach our pubic tubercle medially and deep, we then exchange our monopolar scissors for our progress forceps to begin our hernia sac dissection. We use a combination of sliding and peeling to separate the hernia sac and cord structures. And here we can see that the peritoneal reflection is completely removed from the cord structures and lies flat below it. An important note here is that the progress forceps can hold greater tension on these structures and therefore is generally used as the arm to create a downward tension, while our bipolar forceps in our left hand can assist with more of the meticulous dissection. In addition to reduction of the hernia sac, it is also important to clear any fatty cord lipomas from the cord structures. This not only ensures that our mesh will lie flat, but may help to also decrease the sensation of recurrence for patients and therefore decrease their pain. Once we ensure that our hernia sac is completely resected and the cord structures are free, we continue this dissection laterally through a retroperitoneal flap. This maneuver will ensure a flat surface for the mesh and therefore decrease risk of hernia recurrence. We then use a medium-sized self-fixating mesh inserted through our lateral port with the medial aspect crossing over the pubic tubercle. The mesh itself is folded into quarters with the opening facing cephalad. The mesh is then unrolled with the inferior aspect of the mesh approximately 1 centimeter above the peritoneal reflection. This again ensures that once the peritoneum is closed, that the mesh will lie flat. Another maneuver that we do to prevent recurrence and to ensure that the mesh stays flat and to avoid inferior recurrence is to create a mesh keyhole. Here you can see we are separating all of the tissue away from this portion of the mesh and creating a flap about twice the length of our cord structures. We will then use 2 forceps to place this flap behind the cord structures. And here you'll see that once our cord structures are secured behind this mesh and approximated to each other, that there is significantly less risk of any contents herniating through. During this process, we are careful not to grab any tissue as we approximate the mesh ends. We are also careful not to strangulate the cord structures within this flap. Once the suture is passed several times, the suture is cut and our dissection and mesh placement is complete. We finally turn to closure of the peritoneum. As seen in a patient with a unilateral inguinal hernia, the peritoneal flap is closed with a 6-inch bar suture. When a patient presents with bilateral inguinal hernias, we close with a 9-inch bar suture, bearing the mid portion of the suture through the medial umbilical ligament. Through these techniques, specifically the lateral flap dissection, as well as the creation of the mesh keyhole, our average operating time for both unilateral and bilateral inguinal hernias is 51 minutes. We have decreased our recurrence rate over the last several years from 16% to 0%. Thank you for your time.